As you know, we are in the midst of a revolution of immunotherapy for cancer. However, some immunoresistant cancers, such as glioblastomas, remain refractory to treatment with poor prognosis. Thus, it is crucial to gain more insight into the immunosuppressive activity of the tumor microenvironment and explore ways to convert an immune-resistant tumor to an immune-sensitive one. My name is Ivy Han, and I am a second-year medical student at the University of Pennsylvania, interested in the intersection of cardiology and oncology. Have you ever thought of the heart as a way to monitor the vagus nerve and the pathogenesis of immunosuppression in cancer? Today, I will be talking about the role of heart rate variability as an index of vagus nerve activity in glioblastoma and other cancers. Glioblastoma, or GBM, is the most common and aggressive primary malignant central nervous system tumor in adults. GBM continues to have a very poor prognosis and is inevitably fatal, despite novel therapies and thousands of patients enrolled in trials. Over the past 3 decades, survival has improved by only a few months. The utility of novel therapies for GBM remains limited, secondary to the blood-brain barrier limiting sufficient intracranial drug delivery, the plasticity and thus heterogeneity of GBM tumor cells both between and within patients, the invasiveness of the cancer, and the unique immunosuppressive tumor microenvironment, including but not limited to IL-6, suppressed T-cell activity, increased immunosuppressive tumor-associated macrophages, increased immune checkpoints, and decreased antigen presentation. Accordingly, immunotherapy targeting GBM has been evolving rapidly, including but not limited to immune checkpoint inhibitors, CAR T-cell therapy, dendritic cell vaccines, and oncolytic viruses. While some of these approaches show promise in extending survival, combination strategies that synergistically target multiple aspects of the tumor microenvironment may have the highest therapeutic potential given the high degree of immunosuppression in GBMs. The possible role of the vagus nerve to alter the tumor microenvironment was hypothesized by Dr. Stephen Brem in a recent publication. According to Dr. Brem's hypothesis, the vagus nerve could potentially affect cancer development, progression, and invasiveness by lowering the production of immunosuppressive cytokines. To dig a little deeper, the vagus nerve may play an important role in cancer through what is known as the inflammatory reflex. Stimulation of the vagus nerve produces acetylcholine, which binds to alpha-7 nicotinic acetylcholine receptors expressed on cytokine-producing monocytes, macrophages, and stromal cells. This inhibits the nuclear translocation of the NF-kappa B signaling axis, decreasing levels of pro-inflammatory cytokines including IL-6, TNF-alpha, and IL-1 beta. In preclinical and clinical studies, IL-6 in particular has been linked to glioma development and stem cell proliferation, heterogeneity maintenance, angiogenesis, invasion, alternative immunosuppressive M2 macrophage activation, and prognosis. If vagus nerve activity is reduced in cancer and associated with prognosis, stimulating the vagus nerve may have therapeutic potential in cancer. But how can we measure vagus nerve activity in cancer? The answer lies in heart rate variability, or HRV. This is a non-invasive marker used to assess the autonomic nervous system. The first written descriptions of heart rate, measured by timing the pulse with a water clock, are found in the writings of the ancient Greek physician Herophilus from around 2,300 years ago. Since then, many more methods have been developed to measure changes in heart rate, including what is known as measures of heart rate variability. HRV analyzes the variation in NN intervals, which are RR intervals of normal sinus heartbeats on an electrocardiogram. Autonomic regulation of HRV is complicated, but in general, increased HRV reflects increased parasympathetic activity or decreased sympathetic activity. On the other hand, reduced HRV reflects decreased parasympathetic activity or increased sympathetic activity. This means that HRV should be directly correlated with parasympathetic vagus nerve activity. There are a variety of HRV parameters, but two commonly reported HRV measurements in the literature are SDNN and RMSSD. SDNN is the standard deviation of NN intervals, often reported over a brief period of time, such as 10 seconds or 5 minutes. SDNN less than 50 milliseconds has been associated with higher risk of mortality in patients with chronic heart failure, and SDNN less than 20 milliseconds is predictive of all-cause mortality in middle-aged men. RMSSD, the root mean square of differences between successive NN intervals, is essentially the average absolute change in NN interval between beats. Since beat-to-beat changes in heart rate are mediated by changes in parasympathetic activity, beat-to-beat HRV parameters like RMSSD may be a good index of isolated vagus nerve activity. However, links have been found between vagus nerve activity in both RMSSD and SDNN. For example, vagus nerve stimulation has been shown to lead to increases in both of these HRV parameters. So now that we have an index of vagus nerve activity, our focus turns to how these parameters change in cancer. To characterize vagus nerve activity in various cancers, this retrospective study looked at SDNN and RMSSD at time of diagnosis in 5 different cancers. When compared to a previous sample of healthy adults, log SDNN and log RMSSD were both significantly lower in this sample of patients with cancer. Over half of the patients with cancer had SDNN less than 20 milliseconds, which was the cutoff previously found to be associated with all-cause mortality. Furthermore, log SDNN was significantly lower in advanced disease compared to minimal or moderate disease, indicating that SDNN can be a marker of cancer progression. A recent retrospective study looking at HRV and hematologic malignancies had consistent findings. In patients with relapsed or refractory diffuse large B-cell lymphoma treated with CAR T-cell therapy, patients with SDNN higher than the median of 12 milliseconds prior to cell transfusion had a 4.85 times greater chance of surviving compared to those with low SDNN. This was independent of performance status and disease status at cell therapy. Among patients with severe disease, 100% with low SDNN died, while only 37.5% of those with high SDNN died. In patients with multiple myeloma treated with autologous hematopoietic cell transplantation, patients with RMSSD higher than the median of 30 milliseconds prior to cell transfusion had a 5.23 times greater chance of not progressing compared to those with low RMSSD. This was once again independent of disease status at cell therapy. Among patients with severe disease, 100% of those with low RMSSD progressed, while only 1 in 3 with high RMSSD progressed. These findings together suggest that vagus nerve activity independently predicts prognosis in patients with both relapse refractory diffuse large B-cell lymphoma and multiple myeloma undergoing cell therapy, with huge differences in prognosis between patients with high versus low HRV. Another retrospective study of patients with ovarian cancer also looked at SDNN and RMSSD at time of diagnosis, using a cutoff of 10 milliseconds for low versus high for both parameters. They found that overall survival was 26.4 months for patients with low SDNN, compared to 45.1 months for those with high SDNN. Both SDNN and RMSSD were independent prognostic factors in multivariate analysis, with a twofold higher risk of death among patients with low HRV compared to those with high HRV. Thus, consistent with the vagus nerve's important role in immunity, HRV, an index for vagus nerve activity, was found to be decreased in a variety of cancers and serves as a prognostic marker for cancer severity and outcomes. There have been early efforts to target vagus nerve activity in cancer through HRV biofeedback, or HRVB. HRVB is a non-invasive manner of self-activating the vagus through slow-paced breathing, around 6 breaths per minute, while receiving feedback on one's HRV so that heart rate oscillations are in phase with respiration and heart rate rises and falls along with the pattern of the tidal breath. Compared to the normal respiratory rate of 12 to 20 breaths per minute, this deep, slow-paced breathing with synchronized heart rate changes increases heart rate variability. In a pilot match-controlled study of 6 patients with stage 4 metastatic colon cancer, 3 patients underwent HRV-B for 3 months in addition to usual care, and were matched on type of chemotherapy and baseline CEA levels to 3 controls receiving usual treatment. The endpoint was CEA levels over time, which correlate with disease burden and prognosis. The study found that patients receiving HRV-B had notable reductions in CEA levels at all 3 time points, while controls did not. Given that this is a very small study, further investigations on a larger scale is definitely needed. Furthermore, other methods of stimulating the vagus nerve should be explored as well. In particular, vagus nerve stimulation, or VNS, may be promising as an adjuvant immunotherapy to reduce pro-inflammatory cytokine levels and activate the immune system to fight cancer. VNS uses a pacemaker-like device to send electrical pulses to the vagus nerve. It's minimally invasive and generally well tolerated, with mild temporary side effects like hoarseness or coughing. Complications are rare and include infection, device malfunction, or vagus nerve irritation. The device can be removed if needed, but this is rare as well. VNS has been found to be safe and efficacious in inhibiting cytokine production and disease severity in rheumatoid arthritis. VNS has also been found to stimulate tumor-infiltrating lymphocytes, activate dendritic cells, and arrest proliferation of myeloid-derived stem cells in preclinical models of lung cancer. Importantly, these effects of VNS can synergize with other immunotherapies like immune checkpoint inhibitors, dendritic cell vaccines, or CAR T cell therapy to halt cancer progression and prevent recurrence. Based on the high level of evidence linking HRV to cancer prognosis, I propose that HRV could help us assess for vagus nerve stimulation indication in patients with cancer, especially if patients with low HRV might benefit most from VNS. Furthermore, in addition to biomarkers such as serum IL-6, CRP, and cytokine panels, HRV could serve as a dynamic, easily accessible, non-invasive, real-time biomarker to adjust frequency, pulse duration, and output current of vagus nerve stimulation and evaluate the response to therapy. This is especially important due to the difficulty of interpreting MRI findings of cancer progression versus treatment-related necrosis. Overall, the high level of evidence linking heart rate variability and vagus nerve activity to cancer prognosis, along with the safe and effective treatment modality of vagus nerve stimulation, means that heart rate variability guided vagus nerve stimulation could emerge as a promising new immunotherapy that could aid in the treatment of cancers such as glioblastomas, converting the tumor from an immune-resistant cancer to an immune-responsive one. These are the references for this talk, and thank you so much for listening. Please feel free to reach out with any questions.